Good afternoon, and thank you for joining our web seminar, Narrowband Imaging Technology for Optimal Visualization During Colonoscopy. This afternoon, we're in for a real treat. In addition to providing general gastroenterology care, our guest speaker performs advanced therapeutic endoscopy procedures such as ERCP, large polyp resection, Barrett's ablation, and endoscopic obesity procedures. After graduating from Harvard College and Harvard Medical School, he completed his residency at the Beth Israel Hospital in Boston, his fellowship in gastroenterology at UCLA in Los Angeles, and an advanced fellowship in interventional therapeutic endoscopy at the Wellesley Hospital in Toronto, Canada. Our guest speaker is currently a clinical professor of medicine at NYU School of Medicine. Throughout his career, he has co-authored many articles on his research and presented results at several scientific meetings. He also edited the textbook, Comprehensive Atlas of High-Resolution Endoscopy and Narrowband Imaging. He has directed many national courses and served as past president of the New York Society for Gastrointestinal Endoscopy. And in his spare time, he enjoys playing hockey. Allow me to extend a very warm welcome to Jonathan Cohen.
Thank you so much, Amanda, and hello, everybody. However remotely, we're going to try tonight to do two things. We'll try and get you all to understand better how to use NBI to visualize vascular networks and mucosal patterns in the colon polyps you encounter. And more than that, we'd like to illustrate how we can use the technology advances of the EXERA III system to achieve a high-quality colon examination. When we get started, I want to just mention some of the FDA cleared claims for this technology. During endoscopic observation, NBI enhances visualization of the capillary network and mucosal morphology. In addition, high-definition narrowband imaging enables visual observation of both mucosal and vascular patterns. So we can see some beautiful images, as you, I'm sure, have seen in some of your practices, and we'll go over tonight some of the features that we're actually seeing as we're looking here in white light and here in narrowband imaging light for some of these polyps, small and larger. This is one of my favorite pictures that I've taken in our ASC here. There's a little polyp tubular adenoma by histology, and we're going to, by the end of tonight, you're going to be able to understand some of these features we can see. Here's a little round central dimple where the vessels are all thicker. Here are these little tubular patterns, and here are these round patterns with white surrounded by brown, and we're going to understand a little bit more about what some of that means. On the left, we have a beautiful adenoma by histology that's on a 180 colonoscope, and on the right, we see an image using the H190 colonoscope, and I'll leave it to you to see which might be the sharper image. Other EXERA III Advances include the dual focus mode, which we'll talk about tonight, how to adjust the optics to optimize the scope's resolving power for objects very close to the scope tip. The dual focus, or near focus as it's sometimes called, feature is activated with a push of a button, and the point of focus can be switched between the near focus and normal just by pressing the button that's usually programmed to be on the back of the colonoscope. There are also some other features about the new EXERA III, the passive bending. The insertion section has a soft passive bending section that helps colonoscopes move through acute bends in the colon. And when the scope meets with resistance, the pressure is redistributed. So the insertion tube bends to adjust to the contours of the colon. This is helpful in, for example, retroflexion. Now let's look at some images and under standard and near focus. On the left, we see a small polyp at the appendiceal orifice. As we press the button and move the scope tip close to the image, we can really delineate better the patterns of the polyp itself, as shown on the right. Here's an example of where you can see the advantages of using a near focus. This is a case where a patient who had a large laterally spreading tumor had ink marks, as you can see on the image in the upper left. And we're doing a surveillance to see if there's residual polyp. And in looking at this thing, you might be able to discern a little bit of a bump, okay, over here. Under narrowband imaging, on this image on the right, we can see the bump a little bit right here in the same area. But then under near focus, by pushing the scope up to the tip, you can see over here under white light on the left, and here on the best here on the right under narrowband imaging. I am circling it now with the cursor. You can see this area where the distinct polyp and recurrent small adenoma is located. Of course, you have to be able to know where to look. This is an image here, or retroflexion, in a case I did, screening colonoscopy in a 50-year-old gentleman who had this polyp right here, the only polyp on the entire exam. So it's important not just to use your imaging, but to really look and inspect all of the mucosa, of course. Some other advances: high force transmission allows one-to-one transfer of pushing and rotating forces to the distal end of the colonoscope to improve ergonomics and scope responsiveness. And something I like a lot, the pre-freeze, or I call it freeze frame. The EXERA III has a dramatically increased sharpness and clarity of the still image capture due to its still image capture algorithm. So much like on a camera, when you take a picture and it takes 20 shots and averages it out to get you a very good sharp picture every time, when you hit the freeze frame, you can really see something still in motion. You can actually has image stabilization to allow time for you to assess the details. And that's what we're going to be doing tonight. Now, I got into this whole area by a sort of a little fluke. Doug Rex was supposed to come to New York to lecture on narrowband imaging in 2006, and his son was in a basketball championship. And he called me with a week or two left and said, I can't come. And so I said, well, let's get the equipment in, and I tried it out, and I got up to speed and had to give his lecture. And I said, this is great, but we need an atlas so we can help figure out what it is that we're looking at. And this here is the second edition, and many of the images I'm showing you tonight come from this edition. So now let's turn to NBI application to visualize the vessels and the mucosal patterns. Now, the first step, of course, when you're using these advanced images is you have to have a clean colon. Now, we all say that, but this picture really illustrates quite well. You're not going to be able to see many of the features on the image on the left. You really need to have a really clean colon in order to really benefit maximally. I put it to you, on this image over here, how often would you in your practice notice these small adenomas if there were any residue? And by the way, I hope you'll notice that there's not just one polyp here, there's another polyp just a little bit above it. I'm circling it right now. Okay, that's the kind of clarity we're going to need to have. Here on this polyp on the right, you see this little blood vessel. It stops right short of where the mucosal pattern changes, and that helps tell where things are. With a little bit of stool, you're not going to be able to notice that. Now, some visual aids. Take the seconds to analyze the patterns in real time as you're going along. As you're going by your colonoscopy, stop and actually look and freeze the frame, especially using the freeze frame technology I mentioned, to get a nice image to allow yourself to focus on the polyp features. We come back to that earlier slide. These are all images just by stilling the frame. If there's any motility, it stops. I can see a nice image. I can look at it, think about what it is, unfreeze it, and go along and proceed with the procedure. So what does it do with this prep? Well, there are a couple of benefits by having a great prep. One is those thick folds. If you can really look at the folds to make sure that you're not going to snare off a fold that really has normal pit patterns, allowing for recommendation of the proper surveillance. What happens when you snare a small polyp and you might lose it? You have to be able to understand a little bit of what it is beforehand. And then when you see some signs that are warning signs for advanced histology or cancer, This is very important because it may alter your management. Perhaps you'll definitely inject that polyp, or not. Maybe if you think it's a cancer, you won't try to take it out. So some tips about the quality of inspection. We're going to focus when we do this on the color differences from the background compared to the polyp, looking for sharp areas of demarcation, any areas of nodularity, or areas where the surface tends to depress or elevate. We're also looking for areas that are sometimes hard to visually inspect. We saw the turnaround view in the cecum. The flexures are particular areas, anywhere there's residual fecal material. The key is to be humble and compulsive, insist on complete inspection. I'd like to show this slide from a paper by Tadapalli, but calls it the egg drop soup sign. Hope I'm not offending any of your appetites. But if you see a clean colon with an area that there's a little residual stool material in one spot, then you should suspect maybe there's a flat polyp in that area, perhaps a flat serrated polyp. And here's another area where you can also see in this polyp where the blood vessels cut off abruptly. That's another little sign to look for these subtle lesions. Just a little bit about the science of narrowband. By using blue and green light from the scope itself, these lights are absorbed by blood vessels, by hemoglobin, and therefore they look dark. That's the most important thing. But I think you want to know also that when you're using these narrow bands, they don't penetrate as deeply, and there's less scatter of light. That also helps give you the sharper image. Here's a nice picture of normal colon mucosa. And it's just training ourselves to look much more closely at the surface of the area. And you hear the thin capillaries are the here in brown, and the deeper blood vessels, veins are at this greenish hue. But this close focus is something we train ourselves to do so that we can see the polyp behind the fold or the wolf that's happening to lie behind the tree. Okay, how to do it. So, color differences, then we look at the vessels, vessel patterns, and then we look at mucosal patterns. And we're going to go through all three in the subsequent slides. Look at this polyp. You see there's very little difference between the background and the polyp itself in this polyp. All these polyps, as I define, are going to be what the histology has shown them to be. So this is a hyperplastic polyp. Look at this slide. This is not a polyp. This is a horsefly, and this fly shows a difference in its color and a sharp demarcation between the edges of this abnormal lesion and the background surface. Similarly, look at polyps. That's how we look at polyps. We can see the difference in color in this polyp, which is an adenoma, from the background, and we can see it well. You've seen this picture earlier, the 180 view of a tubular adenoma. It has very brown, irregularly thickened vessels, and the color is definitely different from the background. But now we're going to turn to talk about the vessels themselves. Again, those are the lesions that turn out to be black on narrowband imaging. These are the vessels. Some of them are thick, and some of them are sort of a disarray. The science behind it has to do with, as you get more disarray and thicker vessels, that's what you tend to get when you get higher grades of dysplasia. And that's sort of the basis of the principle for what we're talking about in looking at these patterns. Look at this hyperplastic polyp. You barely see any pattern at all, maybe some faint little vessels, and they're in a uniform array. And here's a chromoendoscopy view of these stellate hyperplastic pit patterns. These are all versions of tubular adenomas. These have thicker, more irregular brown vessels, but they are somewhat uniform as you go around the area. Excuse me, here we go back. And now look at these in contrast. This polyp is actually a cancer in a polyp. And there is a depression, if you can appreciate, in the contour. And let's look over here with near focus at these vessels. The vessels, some of them are thicker, like this one over here, and this one over here, and this one over here, and they are really no discernible regular pattern. All these are warning signs for a more serious degree of dysplasia. Now we're looking at the mucosal patterns, because the vessels line the pits. Therefore, you can see that as if it had contrast, you can see with narrow band, you can see sometimes somewhat of the pit pattern. Here you have these long tubular white areas in between the vessels, and you see them both on both sides. Now, there are different patterns that are typical for histologically confirmed hyperplastic polyps. And here we have where you see some fine capillaries, these little lines, but you really don't see much pattern at all. We call it a bland pattern. Here's another example of a bland pattern. You really don't see much there. And of course, the color is the same as the background. Here's a third example. Okay, you can see these little fine little lines there, the vessels, but it really is a fine capillary network. Now there's something different. These are dark spots surrounded by white. Now that's a characteristic finding that you see sometimes in the pattern that you see with hyperplastic polyps. Let's look at another example. You see the dark spots surrounded by white. It's very uniform and regular. This is a hyperplastic polyp. This is another one. In fact, there are two of them here of the same pattern, the dark spots surrounded by white. Now let's look at some adenomas. Adenomas has just the opposite pattern. We have a white spot surrounded by the dark vessel, and that's the pattern characteristic in a tubular adenoma. In this tubular adenoma, you see the same thing, these beautiful white central areas surrounded by the vessels. Here's another example of the same thing, white surrounded by dark. Now we see a different pattern. The vessels are in more of a brain-like gyrus pattern called a tubular gyrus pattern, and it's something that we see in this tubular adenoma. So we can see here's another one where you see a tubular adenoma which has this gyrus pattern that you're looking at. Over here we have a tubular gyrus, and there's a little bit of a central area which we'll talk about in the middle, which is a little bit thicker. This is a little darker in this image, but you can see the same brain-like pattern, gyrus pattern of a tubular adenoma. In contrast, white dots with brown in this adenoma, dark dots with white around the outside in this hyperplastic polyp. This is the level of focus, what we're doing. We're focusing on the mucosal pattern. In this one, we can see two mucosal patterns. One, we have the white dots surrounded by dark, and then we have this more gyrus pattern over here within the same polyp, which is an adenoma. So can you describe this pattern? So it's the same idea, whether it's in white light, and you can see it a little nicer here in the narrow band image, but you can see the difference in color. You can see the vessels, some of these darker vessels that are there. They don't look too thick, and they also are in looks like a little bit of a tubular gyrus pattern in one area, and this is in fact an adenoma. How about this polyp? This polyp, we see the dark spots, and we see white surrounding it. The first step is to see that, and then you can recognize its association as this hyperplastic polyp. This one here has an image that looks like the gyrus pattern of a tubuloadenoma, and it is by histology. Here we see a bland pattern, and here we see the dark spots with white around them. Both of these polyps are hyperplastic. Here we have the white dots with the black around it, the pattern, and here we have the tubular gyrus pattern. Both of these polyps are adenomas. A little bit about the valley sign. Now, you may have heard about depression as being something that's a concerning thing for cancer. But if you see a small dip in the middle where there's an increase in the number of vessels, that actually is a sign of tubular adenoma, and I'll show you that. We showed you that in the beginning. Remember the first image? See this little area in the middle? You see a thicker and more higher density of little vessels, but they're still very uniform. And it's only a millimeter or so big, so it's not a big central depression. So that's something that we see often in cases of tubular adenoma. Here are a few other examples. You see there in the middle. On this polyp here, you see a little area. It's a little bit depressed in the middle, but it's just a small area, and it's uniform. So this is just a tubular adenoma. Here's another one over here on the left, and over here on the right, you see the thicker vessels with a little bit of a slight depression in the middle, or a small little dip. Now look at the difference between this central valley versus this larger area, which is much more depressed in a much bigger area. This one on the right is actually has a high-grade dysplasia. This polyp over here also has a central area that's depressed, but this is not a little valley. This is a whole central depression. And let's look at these vessels in detail. Look how thick and irregular they are. This is a cancer. So this is a case where this one is being injected to try and be resected, but this is a cancer in this particular polyp. This polyp is a little more subtle. This polyp, one might go and just smear this polyp off, but if one notices this area where the pattern changes, and they get a little bit thicker, more regular vessels in that area. So that's concerning in that area. And this polyp, I actually took this one off. I injected it and took it off, and it had a little bit of high-grade dysplasia in it. And by virtue of the pattern, I really was more careful about that polyp. Here's some polyps on the stalk. We've been showing a lot of sessile polyps. We can see our polyps on the stalk too. This is a tubulovillous adenoma. Even though these vessels are sort of thick there and are sort of a uniform pattern. Now let's look at this polyp. This polyp looks a little bit over here on the right like if anyone was from New Hampshire, it looks like the old man in the mountain, but this one here, a little bit of a nose and there, but it's a central depression and some very thick irregular vessels, and this polyp actually was a cancer. A little bit of background now. We're going to go over review some of the things we did about color, vessels, and surface. Color, vessels, and surface. Let's just go over it and think when you're looking at these slides is how you would assess them when you're doing your endoscopy. Now these are done with 180 scope, so it's there. So we're looking at this one, and we're going to see this polyp. The color, it looks a little different from the background. To me, I see a brown vessels, and it looks like a tubulogyrus pattern. So that's how I would describe it. Obviously, I'm taking it off here with a snare. And let's look at this one. Now, this color looks exactly the same as the background, okay? Same with this one, about the same as the background. We don't see much in the way of vessels, and we don't see much of a surface pattern. This was a hyperplastic polyp, as was this one. Let's look at this one. The color. Is the color different? Yes, it's different from the background. Are the vessels, are they brown, around white? I think so. It looks a little bit of a pattern of more of a branched sort of a tubular gyrus pattern that we saw with the adenomas before, and that's how we would describe the pattern. Let's take another practice one. Look at this one. Is the color looks the same as the background. The polyp vessels, I don't really see very much. If you look carefully, maybe we have those little brown vessels there. They're very either no vessels or lacy, I would say, or maybe they're the brown vessels. They're little brown vessels with a white around them. You can discern it. Perhaps you'd see it better if you had a 190 scope. And then you go down to the pattern, and you see maybe the dark pattern surrounded by white in this hyperplastic polyp. Okay? Now, thick fold, the point I made before, if you see this thick fold and see that they're normal pits, you'll be much less likely to try and snare that off and perhaps just take a biopsy. Now, I want to focus a little bit in the remaining time about margin assessment. I think it's really important because we know that complete polypectomy is a potential future quality target, that incomplete polypectomy has been associated with higher interval cancer, and we were going to try and do better vessel and mucosal assessment before and after we take the polyps out to really do our very best to get the whole polyp out. I want to show you some slides here. I call it the iceberg effect. This is a patient who comes back. An outside doctor did a partial polypectomy and realized that maybe didn't get the whole polyp out. And so I brought the patient back for sort of round two. And we see in white light the area, there's a little scar here. and we see this little area there. We say, aha, there's a little bit of residual polyp. Great. Okay, that's what we see. Look carefully at the subsequent pictures. So this is a closer up near focus view, and you see a little bit better some of these patterns of vessels that look adenomatous in this area, and these look like they're normal areas around here. But if you look with narrow band, you see this entire area, all this flat area over here with those same gyrus patterns of tubular adenoma. So there's a lot more work than was met the eye initially. And here is with near focus. You see the near focus sign when you hit the near focus button. But let's look over here where it's obvious. Let's look where my cursor is right now. You see where it is right now? All that area, you can really see the extent of that adenoma. And here's another view of it, looking up around the edges of the border so you can make sure you get the entire polyp. Pink rim sometimes accentuates the margin. That's a help when you're using narrow band. This polyp, which we showed before, not only do we see the abnormal vessels here, but we also see very nicely the full edges of the polyp to know that we have to get this part of the polyp out too when we're doing our resection. Of course, it's easier when you have a nice stalk, but sometimes the polyp can extend down the stalk, and so it's very important to really analyze the stalk closely, and I do that in near focus as well. Every time I do a polyp, when I'm done, I look at the edges, I look at the pit pattern to see that I got the whole polyp out. Here's a nice image with this is just with zoom with a 180 scope, but you can see around the edges a normal round pit pattern after taking the polyp out. In this case, I did a cold snare polypectomy, and this is a near focus, narrow band imaging. And you can see these little beautiful uniform dots of the normal pits surrounding this complete cold snare polypectomy. So to conclude, a high-quality exam requires an excellent prep, excellent inspection technique, and superb imaging capabilities. The EXERA III HP190 colonoscope with the dual focus is designed to enhance inspection and visualization of both vessel and mucosal patterns like we showed you today. So you can inspect the colon and get images like this. And this technology is very helpful. And I would add to that along with this technology, what is required for really good quality examination is always a highly attentive, focused, and discerning eye. Thanks so much for your attention.
Thank you for that insightful presentation, Dr. Cohen.
You're very welcome.
We will now move to the Q&A portion of this afternoon's presentation. To ask a question, select the Q&A icon. The Q&A icon can be found in one of two places. In window view, the Q&A icon can be found on the upper right side of the WebEx screen. When in full screen view, pull down the WebEx toolbar from the top of your screen slide and select the Q&A icon. If you don't see the Q&A icon, click the drop-down arrow to find it. To submit a question, type it into the pop-up box. Leave the Ask Center on all panelists. I can see that we have a number of questions. Should we not get to your question, please don't hesitate to contact your Olympus endoscopic area manager. If you don't know who that is, contact us via our website, medical.olympusamerica.com. Dr. Cohen, our first question today is, how long does it take you to get familiar using NBI?
Well, some of the uses you can become familiar within just a single case. Learning how to press the button and turn the button off, and then learning how to press the near focus takes a little bit longer. But so one case, and certainly one session in your endoscopy unit, the near focus takes a little bit of time just to get used to moving the scope tip close to the lesion you're targeting. In other words, when you press the near focus, if you're in the lumen far away, it'll look blurry. So you have to push the tip of the scope close enough to the actual lesion, and then you see those sharp images which we showed you in the talk.
How much time do you think that you have to allocate to examinations when adding NBI?
Okay. Oh, and actually, I would like to add also that to see those patterns that we talked about today, I'd like to hope that after going through this webinar that perhaps you'll jumpstart your ability to recognize patterns. But that takes a little bit more time to become adept at looking at it. The key is to still the images look, and then I often write a little note to my pathologist, and I get some feedback as to what I thought it was and what they are, and that helps accelerate the process of learning. It doesn't take too long, but to answer your question, if I'm going to do an examination of a regular screening colonoscopy and I'm going to use NBI, it just takes a couple of seconds. If I find a polyp and I want to assess it with NBI, I turn the button on, that's a second. I turn the button off, it's another couple of seconds, so after I've snapped a picture. If I'm going to be using NBI to look at an entire part of the colon, however, it takes a little bit longer. In studies, it takes about 30 to 60 seconds longer to examine the colon when you're using, say, narrowband to look at an area after looking at white light as you go through the segments of the colon. So it depends what you're using it for, but it really doesn't add too much time to the procedure.
Thank you, Dr. Cohen. We have another question. The question is, do you inspect the colon under white light or NBI light first?
Well, I always go under white light on my way in. If I find a polyp on the way in that I want to assess, I'll go temporarily to narrowband imaging to look at it if I want to look at it and take the polyp off before I've got to the cecum. But assuming I'm going in under white light, on the way out, I'll look at the area under white light. I'll make sure the most important thing is to clean up the segment if I'm going to be using NBI. I find it's easier to look under white light if there's a little bit of pool of residual fluid than where the pool color is yellow, as opposed to the pool of residual material would be pink if it's an NBI. I find that harder to look at. So either way, I'm really going to do a good job at the flexures, for example, of suctioning out residual fluid. But yes, white light first, and then if I'm going to look at the whole area under both white and narrowband, I will look at a segment of the colon, say the cecum and in the right colon under white light, go back to the cecum, and then come back under narrowband. And I'll do it segment by segment like that if I'm going to look at the entire area rather than just sporadically look at a particular polyp.
Thank you, Dr. Cohen. Excellent response for that question. We have another question about how you use NBI. Do you use it in real time, during scope passage in, during withdrawal? What's your practice?
Yes and yes. I'll use it. I use it as I need it. I mean, I think that it's not a big deal to use it. Once you get familiar with it, it's just I'm very. It takes an extra second or two when I'm looking at an area. Sometimes when you look at an area, you'll take your scope and you'll turn the scope in one area, in one angle or another, to look at something in a few different perspectives. You try and get a feel for what it is. It's the same thing. You press the button, look at narrowband, you turn it back to white light to look at it that way. So I'll do that if I see something on the way in. I'm not doing much of my inspection until the way out. So, but if I do find something, especially something small, of course I will, like anyone else, I'll fully inspect it before I take it out, for example.
Thank you. How do you deal with motility when trying to examine a polyp with NBI and near focus?
Well, I try not to curse or anything like that, but no, I think that the freeze frame function I showed you really helps out quite a bit. If there's a little bit of motility and you still with the freeze frame, you still a picture. Oftentimes, even though it looks blurry to you endoscopically, the scope will get you a still image that actually will allow you to discern what you were trying to look at. Then you can look at it, assess it, and then you can freeze the picture and then go back to live and proceed. Now, in certain cases, if there's a lot of problems and you want to do some therapy or one thing or another, a small 3mm cap on the tip of the scope can be pressed against to fix the lens between the lens of the scope and the mucosa to help with your near-focus magnification. I use that mostly in the esophagus and less in the colon. But, you know, that is another thing if really motility is a problem and say you're trying to do resect something and you want to assess it.
Thank you, Dr. Cohen. We have another question in. The question is, will NBI help me raise my adenoma detection rate?
Well, you know, it's interesting. I hope that any efforts you do to improve the visualization of the colon will help you improve your adenoma detection rate. I think that it's been, you know, a lot of folks have been working on ways to improve the ADR in varying different ways. I think the first important thing is, are your preps clean? That's the low-hanging fruit. In order to do good NBI, you have to have a good, clean colon. So I think getting a clean colon is the low-hanging fruit. Doing a better job of inspecting all the areas, those are critical. If you look at the papers on narrowband and white light, you'll notice that most of the papers do not show an improvement in adenoma detection rate compared for narrowband compared to white light. There's some papers that suggest maybe some decrease of miss rate, but really all those papers, if you look at the numbers, you're talking 40% ADRs in both the white light and the NBI group. Now, I think what you're seeing is a lot of folks are, A, they're using high-definition scopes, and B, they're also looking real carefully and they're focusing. Their eyes are trained to look really carefully the way we were talking about tonight when we were looking at polyps. So I think the process that we're talking about generally will improve one's skill and one's attentiveness. But NBI over white light per se in the literature has not led to a higher ADR.
Thank you for that. We have another audience question. The question is, as a fellow, what is the best way for me to gain familiarity with NBI?
Well, I guess you can see that you can see the rerun of this webinar, but no, there's I think the best way you can get familiarity is to use it because it's in a lot of your scopes. It's there. A lot of people just haven't been using it. I think you use it, but then you don't. You use it to write down what you think you see, and then you have to follow up on the pathology report. I think that's a very useful tool, especially as a trainee, to get feedback on what it is that you actually find in the histopathology as it compares to what you saw. I also, I like to. There are atlases. I showed you the atlas from which I drew many of these photographs. They can be helpful as well. And I think that just use it in practice, and hopefully you'll get up to speed before too long.
Thanks, Dr. Cohen. Our last question is, what do you do when you cannot retrieve a polyp?
Actually, the best answer to that is, what did you do before you couldn't retrieve that polyp? In other words, I assessed the polyps really carefully. And then one reason to do so is to make sure if you should not retrieve it, you at least know a little bit about what you were dealing with. And when I say I assess them, I don't just assess them. I also take a really good picture. I think people underemphasize taking a good photograph of what they see so they can go back and look at it again afterwards. I think that's important. It does happen, and you have to make a recommendation about when the patient should come back, for their next examination. Certainly, if I retrieve it, it goes to histopathology. But if I have to, I go back and review my picture and what I thought and how confident I was in my assessment. Maybe sometimes there are other adenomas and polyps that you have gotten, so you can know a little bit better about when to bring them back.
Thank you very much, Dr. Cohen, for providing an excellent presentation and responding to those questions that we had. Audience, if you have any questions, please contact your Olympus endoscopic area manager. If you don't know who that is, please contact us via our website, medical.olympusamerica.com. Dr. Cohen, would you like to provide us with any last words of wisdom?
Well, I just want to thank everyone for joining me this evening. I think there's there's just great images out there, and your interest in it is great, and I think you'll hopefully be able to take some of this back into use in your units right away. Thanks so much.
Thank you. Have a good evening.